Evening. We will be starting the lecture series in about 5 minutes at 6 p.m. sharp. Thank you. Good evening. Welcome to San Antonio Regional Hospital's Cardiovascular Community Lecture Series. My name is Allison Lejean. I'm a registered nurse and the Director of Cardiac Services, and it is my pleasure to kickstart our first lecture series, Know Your Heart, Structure Matters. Just a couple of housekeeping items before we begin. I would ask that you please type any questions you have in the chat section, and we will attempt to answer as many questions as possible at the end of the lecture series. Also, if you have a question that perhaps you don't want us to read out loud, my email will be provided at the end of the lecture, and you will be able to send an email to me and I will get back to you and talk to Dr. Samarany. So it is a great pleasure of mine to introduce Dr. Samir Samarany. Dr. Samarany is a cardiovascular specialist. He was born and raised in Lebanon and is trilingual in English, French, and Lebanese. He is a very thorough and caring physician and believes in the value of patient education. He also has personal interest in information technology and electronic devices, and he's always looking for ways to better utilize and improve patient care and medical practices. Outside of medicine, he enjoys spending time with his family, playing soccer, and exploring new places. He has two daughters, Chloe and Zoe, very cute, and married to a lovely French lady, Danielle, who carries a major in interior architect. His clinical interests and experience include evaluation and advanced treatment of structural heart disease with non-surgical interventions such as TAVR and MitraClip. He also is involved with cardiogram, both 2D and 3D, as well as nuclear imaging and vascular imaging. Please join me in giving a virtual round of applause for Dr. Samir Samarany.
All right, thank you, Allison, for that nice introduction. I appreciate it. Welcome everybody for that series in San Antonio Regional Hospital series. Hopefully you enjoy the first session. To know your heart is very important, to know all the tools necessary that your doctor or cardiologist will order, and to know what nowadays in 2022 we can do so you know your heart better and know your disease so we can treat you better and follow up with that disease very well. So we can start the presentation. All right, if you see the section, I put it kind of in a small iPad template to see. So we'll talk about multiple kind of tools and advanced tools in cardiology, mainly echocardiography, that's usually, or echocardiogram, usually the mostly used, but nowadays we're much advanced, especially in 3D era. And what can 3D do other than nice pictures? Otherwise, also evolution of cardiac CT. And there's a society for it, and cardiac MRI, which is a very powerful tool that also San Antonio offers with all these details and all its powerful kind of diagnostic tools. Last, nuclear test. Usually it's been an old test, but now with new introduction of PET scan, which I'll go into details of each one and explain to you kind of each tool, what we can do to know your heart and know your condition. So we'll start with the echocardiogram. So echocardiography in 2022, you hear that word a lot when you go to your cardiologist's office. So I want to introduce you kind of how many diseases we can diagnose with that test and how many kind of important the steps and thoroughness to read that test to be able to give you the diagnosis, because you can miss a very important diagnosis or very important disease if you don't do the appropriate steps with that tool. And especially with the new technologies that opens up more kind of ability for us to do treatment, non-surgical treatment, replacing valves, which I will go into details. So if you see right now, the first step that also we introduced recently in San Antonio 2 years ago, which we call cardiac strain. It's a modality that we have it's very important to use, and it tells us kind of the movement of the heart in three kind of direction, as you see on the left. The torsion of the heart, the squeezing of the heart, and the shortening of the heart. So you know the heart moves in three directions, and that test why it's important, and it gives us a certain details on each motion of the segment of the heart. Compared to the old school that we only mention how much the heart is functioning, now we can mention a lot of details on the motion of the heart. And why this is important. So one example here, usually sometimes you hear from your doctor telling you that your heart is hypertrophed or thickened in another way. So if you see, in the old days, it tells you that and we stop there. Now with introduction of that strain, we're able to know what type of disease caused that thickness from hypertension alone, which is very common, that caused that thickness, versus a disease called amyloidosis, which is a disease that's common now. We're seeing it more because we have those tools, and it's a disease that carries a toxic protein that builds up inside your heart, sometimes your brain, and it's also associated with dementia also at certain age. And the last one is a disease that you carry genetic or familial, and it's called hypertrophic cardiomyopathy, and that also can affect the thickness of the heart. So now with that strain, we're able to see from that point of view that which disease is causing the thickness by just doing that strain on your echo. And that's a modality that we offer newly and we introduced in San Antonio. Another thing that's important, people who unfortunately are diagnosed with cancer or they receive chemotherapy, and you know some chemotherapy can be toxic to the heart, and we don't want that toxicity to get to the heart, but we want you to get the benefit of the chemotherapy and get your cancer treated. So in that detection, we can detect if there is damage in the heart 3 months before the function gets worse. So that's very important for us. There is a new field now in cardiology that we do, and it's called cardio-oncology field. And I follow those patients, and I'm a specialist in that field. And then what we do is we do the strain, the cardiac strain, to see if there is damage before the heart, as I said, decrease function. That way, we can tell the oncologist that you need to watch out with chemotherapy before your heart gets worse in 3 months, compared to the old days. We'll get, unfortunately, the toxicity, and it's already too late, and we're catching up. Now we switch gears to another thing that we do also on echo, and it's called echo contrast. This is a contrast not like the contrast you receive in CAT scans or other contrast. It doesn't damage the kidney, and that's very important to know. It's a contrast that helps us see your heart better, especially in people who have heart failure. People who have heart failure sometimes end up with a tiny clot in the heart. You cannot see on a regular echo that you do the regular echocardiogram, and you end up with a stroke not knowing where it came from. So when you have that condition, it's very important to include that step. As I said, some steps are very important to save a life or save somebody from a stroke, which is a big deal. And then we see that tiny clot that wasn't seen before because it looks black and we see black inside, so it's hard to differentiate if you have a clot or not. With that contrast, we're able to see, and you see in that image on your right, you see that tiny black dot on the tip of the heart that shows that clot that we saw just by using the contrast. Compared to before, you don't see nothing except black inside the heart. This is another way we see with contrast. So contrast also, it's a very important tool. It's another way to see also with echo, if somebody have blockages in the coronaries or the vessels of the heart, you can see there is viability. Viability meaning your muscle is already alive or your muscle is scarred or not. So what happens is when we give the contrast, if you see it propagates inside the muscle with a certain technology that we do. And if it propagates, that means your heart is viable. If it doesn't propagate, that means there is a scar or non-viable. And that's, you can see kind of on the picture on the right, you can see those black dots inside the muscle that you can see that your heart has scarred in that territory. And that helps your doctor or your surgeon make sure which areas we need to focus on to get your heart better. Now to talk about the most important kind of technology in echo, which is this 3D echo. So the 3D echo is very important, has been for the past 10, 15 years, but it was rudimentary or starting as a little child, as we can say. So the thing is right now with the new technologies, with the studies, with the academic kind of achievements, we're able to know now more use the echo in real life with 3D to introduce little bit couple of parameters that we can see, valves, procedures that we can monitor, which I will discuss with you in details. So in the past, we used to do the 2-dimension. The 2-dimension, as you know, you have an oval shape, but you measure in 2 directions only, but you miss all the other direction because it's not 3-dimension, and the heart is not like very symmetric geometric shape. It's multiple kind of asymmetric shape. So 3D is very important to give you that information. And one of the most important is the size of your heart, function of your heart, which is more accurate compared to the old days with 3D echo. This is an example of kind of what we get with all the chambers of the heart, the 4 chambers, and we can get kind of the heart in 4 chambers and all kind of the volumes or the measurements that need to be done for each condition. Now we switch to mitral valve, which is a big importance with 3D echo. In 3D echo, we can see the mitral valve in a way we call it surgical view. And surgical view is the surgeon, how he sees your heart when he enters your heart, when you're doing an open heart surgery. So if you see on the right side, that's 3D echo, it shows the mitral valve in details with its 2 portions, the anterior and posterior leaflet. And with that technology, we can see the valve like the surgeon sees without doing a surgery, and that's a big deal. We have a couple of diseases that we did, and I will show you an example of a surgery done. And you can see there's this middle part where we call it a chordae was detached, and one piece of the valve has been prolapse, we call it, or that disease, we call it mitral valve prolapse or flail, meaning one piece is detached. And then if you can see on the side, that's the surgery of the same patient. And you can see that chordae is the same exact things that the surgeon seen based on that imaging before the surgery. And that's very important for the surgeon because you can conclude that we can help the surgeon repair the valve, which is much important than replacement, because we keep your own valve, your native valve, and we're able to guide the surgeon in the surgery or before surgery what needs to be done to make sure you fix the valve and get rid of that leakage or other problem with the valve based on what we find. Another way also we can guide, and I will tell in the end, we can guide the surgeon kind of in different ways. We have a 3D model that we can get, and that 3D model tells us which part of the valve is the problem and which part of the valve is not doing its job, either by being retracted or being prolapsed or being perforated or being infected. So all of those are possible conditions. We can give more than 50 parameters for the surgeon. For sure, the surgeon don't want all of those, but each disease has its own parameters, and that's what 3D had opened up that world compared to the previous 2D that we used to do. This is one example, if you see, of a valve in real motion that we see in the surgical view we talked about. And this is a valve being prolapsed in both ends, and you see that black hole in the middle. That's usually where the leakage is happening. So it's as easy as knowing where the problem is and what's going on with the valve in that field. And this is another example of a valve that's So this is another example of the valve. This is the opposite. This is a stenotic valve. Happens usually with elderly when you have more calcium and you see that valve has been calcified and calcium has built up and formed the bridge in the middle, and you can see like 2 eyes kind of situation, or it's formed the valve, and it's compared to the valve I showed you before is completely a different situation. Now, talking about mechanical valve, you see, you can have a mechanical valve after surgery, and mechanical valve, you can see how much accurate we can see how it's functioning. And based on that, we can see for that example where a clot is happening, and compared to the other image I showed you, this valve has a clot on one side of the valve, and we cannot see anymore the function well, and we can diagnose easily and tell the surgeon this is an emergency. Your mechanical valve has a clot in it on one side, and we need to do surgery or other therapy or blood thinners as soon as possible. Now, what's important also in 3D, that we can analyze the picture. It's not only one picture we look at and try to analyze it. We can cut it, We can cut it in multiple kind of layer. We can look at each layer, look where the interest is. And we wanted to see what's going on. If you see in that picture, and I'll replay it again. If you can see, there is a piece on the valve, and that's usually an infection. And that's an infection that lodged on the valve and now infecting the heart. And that's very important, and you need the long-term antibiotics with that. So that's very important to diagnose early, because you can end up with a stroke, you can end up with multiple other problems because of that infection happening in the heart. So it's very crucial to be accurate, and that's why that tools offer that accuracy compared to the old days. This is another example, as I showed you with the surgical part. This is the prolapse of the valve, and you can see the problem on the posterior valve, and that's kind of what we do. This is another technology we use with 3D. We call light technology. And also we can see the mechanical valve. You can see one part is not moving, but also we can see if there is a hole around the ring. You know, the surgeon suture that ring in your valve when you replace the mechanical valve. Sometimes it can detach, and that light technology we can see the light going through that hole. We know that there is a detachment. So that's a new technology and also available in San Antonio Regional Hospital. That's another bioprosthetic valve. As you know, they call it pig valve or cow valve. You can see the sutures, how in details, you can see those details. And this patient, we had to know if the leakage is happening inside the valve or outside the valve, because the treatment differ. And this is an example we know from that 3D view and 3D image with color, that the leakage is happening inside the valve. This is another view of the light therapy. This is an example of infection. And if you can see that two pieces of infection that's flickering on both sides of the valve. And this is, we diagnosed a severe infection of the heart needing surgical therapy in this case. Now, other stuff that we see to shift gear also on the 3D echo, this is a hole in the heart. And that hole usually, we call it PFO or patent foramen ovale. And in the past, it was a little bit hard to diagnose. Sometimes we do other techniques, but in 3D, it's very kind of easy to diagnose if you know the tool and how to do it. And then if you see that hole is very obvious in front of you, and that can cause a stroke in some people, especially young people. 20 to 40 years old with a stroke, very high likely they have this condition. So it's very important to do a very thorough workup. This is another patient that I diagnosed with the light therapy with the Echo 3D. You can see a clot that's moving plus a hole, and the clot in one side plus the hole in the other side. You can see the light coming, and that's an emergency, as I said, because that clot, a piece of it can go through that hole as you see behind, and go through that hole. And that was a recent patient. I did an echocardiogram with 3D in the past year. This is an example of a big clot that people have clotting disease, or they have a rhythm problem, the irregular rhythm that's the most common that we call Afib. And sometimes they can form clot in their upper chamber of the heart. And that's one example of a large clot that we can see and assess if that needs surgery or not, and if it can be treated with blood thinner or not. This is the same example of the hole, but a different way, the PFO, as we said, and then you can see it in a different way. This is a very nice example of bubble study, we call it, but this time bubble study in 3D with light. And that what we see is, we can see the bubble passing through two chambers rather than staying in one chamber on the right to the left. And then that indicates that there is a hole in the heart, and we can see the lights passing through that hole. So that's a very powerful technology to be accurate more than before and make sure you don't miss any. And now, how we fix that hole. Now, also in San Antonio, we can do the PFO closure, and that's without surgery. It's a catheter done through your groin, and the same day you can go home or next day. So we put kind of a occluder device, you see that big circle, and also we can monitor it in 3D during the procedure and after the procedure to make sure we occlude it perfectly. We don't leave any small gap, which is very important if one of the complications of that procedure. Now to move to other valves, also other valves we can see in 3D. In the old days with anatomy, there was a valve on the right side of the heart. We used to call it tricuspid valve because it's made of 3 pieces. But we know of 3 pieces because we do 2D echo. Now with 3D echo, we see patients with 4, 5, 6. The most published was a case report from India with 7 pieces of that valve. So as you know, we're changing anatomy. Now we're finding stuff that we didn't find before. And it's not anymore called, should be called tricuspid valve, but because everybody used to that name from the past, but that valve is more than 3, can be 4, 5, or 6. And this is an example of 4 tricuspid valve, or you can call it quadricuspid valve. This is an example of a congenital disease in a guy who's 20 years old that came to me with shortness of breath. And doing those technologies with 3D echo, we found that he has a very rare congenital disease, which is called bicuspid valve type 2 Sievers, which if you can see, it's instead of the valve being 3 pieces, it's only the 2 pieces joined together in both sides. And that's what's happening. It's opening up in one side only. Also, we can see bicuspid valve that's been for a long time. You have it since age 20, but you only diagnose it when you're 70. And you can see the calcium. You can see those thick lines on those valves, and that's calcium on 3D, and also will tell us how the modality. Now, this is very important one, a technology we use in 3D. We can cut, as I said, in multiple layers. If you see the lines on the right, upper right, and we can cut the lines and see in details each layer, thin layer, to see what's going on in those leaflets. This is a bioprosthetic valve done through the groin. But if you see on the bottom right, on the middle line on the right side, you see that opacity or kind of density that's on the valve. That's a clot on the valve. And it's very, very easily missed with any 2D echo, I can guarantee you, if you don't do that technology or you do CT. So that's very important to know what you're looking for and what tool to use. This is what we call it, calcified valve. And this calcified valve is the most common seen with aortic valve. And you can see where the calcium is deposited and not letting the valve open. And we can see it in details. Also, we can measure how much the valve area is, which is a very important tool to diagnose that condition. And you can see how much it's opening a single piece that's opening where the blood comes to your body. So it's very important to know those details. This is a patient that he was having shortness of breath and heaviness on his chest. And this image, I published it in American Society of Echo. It was accepted from San Antonio. I did it 2 years ago. And this is Emixoma. Emixoma is a mass that's not cancerous, but it's a benign mass, but its location is dangerous. And it's on the upper chamber of the heart. And it's huge. If you can see how much that size of the mass is inside your heart, it goes down when your valve opens, and it goes up when your valve closes. And that mass can cause a stroke, sudden death, because it stops the blood suddenly from passing. So in that way, we knew where it's coming from, what to tell the surgeon, where to focus, where he needs to go. And even later on, when we have robotics, also you can go where you want with surgery. So that's very important, a tool to diagnose that patient, and we save the life by just doing that thorough exam. Now in San Antonio also we do multiple structural interventions. I will not go into details of each one. One of them is the TAVR, and the TAVR usually it's kind of procedure that we put a valve inside your aortic valve, and your aortic valve will be the support of your new valve. So what happens is we go through the groin, no surgery for patients who cannot do surgery, and it has its indication. And then we go with the catheter, we inflate that valve with a stent, and we leave it there, and it starts functioning immediately. And then if you see, we need to do the measurements, because how we know which valve we need to place or which kind of size we need to place, we go by echo, we go by 3D, we go by CT scan, which we have all these tools, and I'm a specialist in all of them, to be able to help the interventionalist or help the surgeon to size the valve and which valve to choose between multiple valves. As you see, there is multiple valves in the market, but there is some that very kind of known to be very well with less complication, and those the two valves we use in San Antonio. Sorry. We clicked on the wrong place, so we'll go there. So you have to see the picture 2 times. All right, so the next one will be the mitral clip, and this is also a procedure that we do for the mitral valve this time for people who cannot do surgery. In the old days, we couldn't do anything, unfortunately, except medication. People were not surviving with that disease. And nowadays in the US, it's picking up, and this procedure has been done in multiple places. And what we do is we go inside your groin, we go above the valve, and we clip where the leakage is based on what the 3D showed us and what's the echo showed us, and then we go from there. This is a little bit example of that leaky valve. And then what we do is for that leaky valve, we go with that clip from top of it, we go and we direct it. That direction that you see in front of you is guided by 3D echo, and it's very important where we cross the valve and where we clip the valve. And that's very important, how to clip and where to clip, because that's the imaging is very important in that situation, because you don't want to mess up in that situation. So you want to be 100% accurate, not even 99. So, and when you clip it, you leave it, and now we clip it, and now the leakage is not happening, and the valve still opens in both ways. And now we have a valve that's functioning, and the leakage is gone. If there is still leakage, you can put another clip based on imaging and make sure there's no complication. So that technology has helped a lot of people, has made people who cannot do surgery live longer, and that's very important in that situation. Now, another procedure that's called the Watchman device. You know, people who have the irregular rhythm Afib sometimes can have a clotting, and we put them on blood thinner, but you know, blood thinner is not something without possible side effects. Some people can be without, but there is a percentage that will have side effects. Now, you don't want to bleed. So what we do is there is a Watchman device or occluder that occlude the kind of the place in the heart where the clot forms the most. And that place is called left atrial appendage. It's a pouch that's useful when we're born, but when you're adult, it's not as useful. And now what happens when you have that irregular rhythm, it becomes a pouch of clots. So if we close that pouch, we prevent those clots from going to the brain, and that's very important. So also with 3D, we can kind of measure that pouch, measure the orifice of that pouch, and we can occlude it and make sure you don't need blood thinner after you're being on it for 45 days after occlusion, and then no more blood thinners needed. And this is kind of an example of that pouch. There is even muscles in that pouch that in the old days we couldn't see with echo very well. Now you can see those pillars that we see the details, and even we can see if there is clots in between them with 3D. So that's powerful tool, will help us a lot, make sure people don't get stroke. And that's very important. And we work with our neurologists very close. Now, something that I want to introduce, and I used to do it back in Northeast at Yale. So what we do is we do something called 3D printing. So when we do the 3D of the valve, either by CT or by the echo, we can print the valve in material and then give it to the surgeon and discuss what we need to do on a live 3D material that's a replica to your valve 100%. I keep going on that picture. I like it so much. So. All right, so now we change gear from the echo, and we'll have the other kind of, it will go a little and faster because echo has more kind of tools that we do. In MRI is a very, very, very powerful tool. As much as I say that MRI, and it's not well used yet, and it's a very powerful tool. We call it in cardiology a one-stop for all. We can see your function of the heart. We can see if there is blockages in the heart, of the vessels of the heart. We can see how much damage there is or scar left, which no other tool can tell you. We can see also if there is swelling in the heart, and that's also important. This is an example how MRI looks and its motion. And you can see here in this patient, there is kind of a hole in the heart. on the lower chambers of the heart that we can see in that muscle is missing a gap in that lower part. So MRI is a very powerful tool. It takes 30 minutes appropriately, and then we can get a lot of information. And I will tell you kind of multiple diseases, which I can speak about MRI for an hour, but we cannot speak an hour for now. So this is an example of multiple diseases in MRI. We see how much scar. Imagine like a footprint. Each disease leaves the like kind of a footprint or a kind of mark inside the heart. That mark is picked up by the MRI. If you have inflammation disease, we call it sarcoidosis, we can see it. If you have an infection due to virus or recently COVID, it has infection in the heart, MRI can pick it up. Echo sometimes doesn't. If you have what we call amyloid, you remember I told you about the dementia or all other the toxic material that build up in the heart, MRI can pick it up. If you have a problem with alcohol-related heart disease, MRI will pick it up. Also, if you have a heart attack and where the damage is, and we need to tell the surgeon or other interventionalist where you need to work, where it's still alive, where it's dead, also it will let us know. So it will show us the scar as the white thing you see, if it is on the tip of the heart or on the middle of the muscle or on the border of the muscle, which every disease, as I said, has a mark. All right. And this is on MRI in a nutshell. And also MRI is very important to mention that it's very important test for the right side of the heart, because your right side is anterior in your heart and then a little bit tilted. So you don't see it well with the ultrasound. So MRI is the best one to evaluate that heart. So know your heart, know which segment is important and what tool you need to use. Otherwise, very important also congenital disease. People was born with holes. People was born with deformities. Their heart is not the same shape everybody has. MRI is a very powerful tool to not miss that. And unfortunately, some people get multiple testing and they miss that hole because not the right tool and not the right step was done. And we had the recent example. And now to go a little bit fast about the CT, the CAT scan, and that's also a powerful tool. The CAT scan, everybody knows the CAT scan, but nowadays we can do a CAT scan that looks at the vessels of the heart. And now we're more advanced with more devices and more technology. So imagine doing an angiogram without a needle. You do an angiogram, go with the groin, people are like afraid, I don't want a needle, I don't want to go to the hospital or get all these procedures, unless needed for sure. But there is a test, you can see your vessels inside without needing a needle and going inside. You can see your plaque, your cholesterol buildup, how much we can estimate your risk of heart attack in 10 years. So that's very important test. And I've been diagnosing a lot of people, unfortunately missed on previous testing that they have a blockage, but wasn't seen on regular stress test. This is how we see it. We see each vessel. If you see the A is the right coronary artery, B is the left anterior descending artery, and C is the left circumflex artery. And the white means the flow is fine. If you see black or we see a little bit calcium white inside it, that means it's an old burden or plaque buildup inside. To give you an example of a patient that I diagnosed, you see that plaque here, the black is building up, and that plaque sometimes if it ruptures, that's the heart attack. It can rupture with stress, mental stress, high blood pressure, infection. So that plaque is very important, and we can see and measure and we can follow with the patient after changing his lifestyle, putting on the right medication. This is another test that tells you the old plaque. You see how white it is, and that's an old plaque, two of them, plus another one in the bottom of that vessel. And you can see kind of tell the patient like you have plaques building up, your risk of heart attack is getting higher, we need to do something. So that's how important that test is. Another thing, I published a case in a journal, and the journal for case report. And that journal, also BMJ, showed that also congenital disease through the CT, you can detect people having their coronaries coming from another place. As I said, you're born with an anomaly, and that anomaly can be dangerous like this case, because that vessel where you say it's called RCA should come from that side on the right, it's coming from the left. and it's passing through two big arteries that's high pressure, and it can squeeze that vessel, and people can have sudden death because of that condition. So when you catch it, you save the life. You know that you need to do immediate surgery and tell the patient that we need to go ahead. And that was published, as I said, recently. Also on another patient also that's been in the emergency room, 21-year-old, that's been multiple times chest pain, shortness of breath. Nobody's able to diagnose. She saw multiple doctors. And then when she came to me and I did the CT in San Antonio at night, she started crying when I showed her the picture and I told her what she has. If you see the line in the upper chambers, should be connected. And that line should be connected completely. And if you see there is a gap, and that gap led to the hole in the heart, and there is mixing of the blood. And that's also what's happening with her. And her right side was getting bigger because the blood is going the wrong direction because of that hole that was missed for the past 2-3 years. And then we did the surgery, and now she's back to playing volleyball with no symptoms. So it's very important which tool you choose, which tool you go, and what you do. Another thing, as we talked about the valve, how we measure it in CT, we can measure the aortic valve. We need to replace it. It's very accurate to measure multiple levels in the valve below it and above it to make sure when we place it in that condition, you don't have a complication and you get the right size. And that's very important too. So, and finally, the last is about nuclear. And nuclear, the new technology is the PET scan. PET scan, you know, people a lot do it in oncology practice or cancer, but now in heart, we can do PET scan. And PET scan is more powerful than the old nuclear test or stress test that used to do. It's more accurate to 95% compared to 80% in the other. If you see a picture there, we can see the activity in the heart. We can know also diseases such as sarcoidosis, which is a rare disease that's inflammation in the heart with no reason. And you can follow it with PET. No other test can follow it except PET. Another thing for women, women have more common something called microvascular coronary disease, meaning small, tiny vessel that we cannot see with angiogram. And they have chest pain for a year too. All tests are negative and you cannot know what's going on. So that test can measure what we call it coronary microflow or coronary flow in the microvasculature. And that we know if that woman have those tiny million vessels that have decreased blood and the right treatment and the pain is gone. So it's very important. Women sometimes are different than men in heart. You need to know where tests to use for women or men, which diagnosis you're thinking. And with all these powerful tools that we have, you can diagnose a lot of disease. Hopefully I didn't bore you with all these details. You can, as I said, any questions you want now or after. I have a website they can share later. So any questions you can have for any of those tools or disease, I'm happy to answer, and thank you.
Thank you so much, Dr. Samarany, for that very informative lecture. We do have a few questions that are coming through, and I'm sure more will be coming as we answer these. But one question was regarding genetic heart disease, specifically the thickening of the wall. This person is 59 years old and their mother was diagnosed at the age of 80. And she was wondering at what age should she start being tested and what would the signs and symptoms be?
It's a very important question. Thank you, Allison, for that question. So as I said in the beginning, with that hypertrophy of the muscle, and there is a condition called hypertrophic cardiomyopathy. And that's genetic, also can happen. We call it penetrance. So in some family, if you have the gene with multiple copies, you can have it at young age, at 20. You can have it at 50, or you can have it at 80, depending on the penetrance. And each gene is different. So we have a 25 gene for that disease. And each person, each disease kind of act differently with the same umbrella of the same hypertrophic cardiomyopathy. So we need to follow mainly the symptoms, mainly shortness of breath, chest pain, dizziness or fainting are very common, especially if you're dehydrated, that happens a lot. And there is a certain condition or medication that makes it worse if you're not diagnosed well with that condition, especially some blood pressure medications or water pills. So what we need is MRI helps a lot to confirm that diagnosis, or genetic testing, or what we do in families who have that condition. We do sometimes echo every 5 years, or genetic testing one time to see if you have it or not. But that's very important to follow on that hypertrophy to make sure you have the disease and the right treatment is for you.
Thank you very much. The next question, should everyone over the age of 50 have a calcium score, coronary calcium score? Sorry about that.
So it's a very important question now. The data has been debatable. Multiple data has been published recently in big journals like New England Journal. So the calcium score is a powerful tool as a packet for people depending on your risk. So what I'm meaning by risk, so let's say somebody who has already blockages in the heart, you already have hypertension and diabetes. You don't need to do a calcium score. We already know you have the disease and we already did the test. Now, if somebody has family history and his father died at age 30, we call it family history for, let's say, below the age of 60. And then you have an early death from a heart attack, you need to have a calcium score with the CT if you have symptoms or even without symptoms to see what your risk is. Another way to see is depending on your risk factors, if you're into the low risk, meaning you don't have any other risk except family, then calcium score is advised. If you're in the middle, we call it intermediate risk. And how we define that risk for intermediate or high, we look at your diabetes, we look at your age, we look at hypertension or not, we look at your cholesterol, which is very important, familial or not familial, which also plays a role. And we look at certain blood tests that's now recent advanced called lipoprotein or high sensitivity CRP. All of those markers give us a clue that your kind of risk of heart attack is such and such. But we can add the calcium score that will add more data. There is a big study called multi-ethnicity study of atherosclerosis, which indicate how much that disease, which is the most #1 killer in the United States, atherosclerosis, how much those plaques of cholesterol build up. And we followed all these people for a long time, for more than 5 to 7 years. And then it showed that when we do the calcium score, we can classify people more. So if you're 50, I need to see all the other risk factors. And based on that, we formulate a plan to get your risk factor. And that's kind of, hopefully that helps.
Thank you very much. Can you please tell us more about your dysautonomia and pulmonary hypertension clinic that was discussed in your bio?
Thank you for that question. So also other than the valves and all other that I mentioned, all other modalities that I'm specialized with, I do also dysautonomia clinic. For people who don't know that word, what does it mean? You know, your blood pressure follows you based on what you do or your heart rate. So if you stand up, your blood pressure should go up. Your heart rate should go up by a certain amount, not a lot. So there is conditions that you're born with. If you have sometimes congenital diseases, sometimes we call it a joint hypermobility syndrome or Ehlers-Danlos syndrome. Those are diseases of the joint. Sometimes you have conditions that lead to problem with the reaction of your blood pressure and heart rate, such as diabetes, lupus, chemotherapy, cancer therapy, other cancer therapy, targeted therapy. So those conditions, what they lead is to your blood pressure drops without a reason and you faint, or your heart rate suddenly goes up without a reason. And we do in San Antonio a tilt table test, and I see them in my dysautonomia clinic. And there is a specific treatment for each condition, and you need to be very thorough in those patients because some of them, as I said, they have very bad lifestyle. They faint all the time, heart racing, brain fog, dizziness. You cannot function, you cannot work. So, and sometimes after an infection, I had it sometimes with COVID or other than COVID, after an infection, you start fainting. So it's very important for those to follow the right test, and that's what I do in my dysautonomia clinic that I see.
Should everyone with a weak heart have an MRI?
So that's a very interesting question. So the MRI, as I said, it depending on what you're looking for. If your weak heart is due to blockage and you found the blockage and your surgeon needs to do bypass surgery or open heart, then you do the MRI to know what's still alive and where it needs to be done to get all the benefit that you need without risking you with complicated surgery with no benefit. Now, especially MRI is good when you don't know what's causing your heart to be weak. So when you don't know your heart to be weak, by all means, MRI should be done. And that will tell you a lot of details, as I said, and sometimes you'll be surprised what you find. And that's very important. So because if you do the regular stuff, echo or other than 3D, I mean the regular kind of old school, sometimes you miss a lot. So there is a lot of advancement in medicine, especially in cardiology, that the MRI plays a role as one-stop shop for everything. And as I said, if you have a heart failure, you don't know the cause, the next step is MRI.
Okay. These are all great questions, everybody. Thank you. Will everyone with chest pain be a candidate for CTA, and do you believe it will replace stress testing?
So that's very important. Recently, there was all kind of the committees. There is a committee for CT, SCCT. There is a committee for echo. There is a committee for the general cardiology, ACC, and the nuclear also. So there were recently a chest pain guidelines, and they recommended where CT plays a role and where not. Europe was a little bit advanced from us, and they used CT before and the class 1. Now both are class 1 because sometimes CT cannot be done. So if you have a kidney infection, kidney dysfunction, or sometimes certain windows or certain body habits that we cannot see, or allergy to contrast. So nuclear usually can play a role. As I said, PET scan plays a role in the tiny vessel disease that CT cannot. CT usually can see the plaques that nuclear cannot. Nuclear only can see the stress test if your blockage is more than 70, affecting your blood flow. CT can see everything. You can know you have a buildup or not regarding. So it all plays a role depending if you have a stents or big stents or material in the heart, CT cannot. There is more advancement coming. There is a lot of in the research. We cannot use it yet in real life, but we've been following that. I've been following that, but it's coming. But my own opinion, I think CT will in the future, but not now. Right now, each one has its own category where to use.
Okay. The next question was, what would be the signs and symptoms associated with a PFO?
So PFO, usually very important to know when you read about PFO, is 25% of the population have it. So 1 out of 4. So it's very common, but it doesn't cause problems. So you don't need every hole you need to go to close it, or like, let's close all the holes. So no. So you can live with your PFO all your time with no problem. When the PFO causes a problem is when you have a clotting or fibers that happen to come from your vein system to your artery system, which they shouldn't connect. So when you have a clot coming from the vein, it can cross that hole and go to the brain. Especially we see it in young people. Sometimes we see it in elderly people, especially if they didn't be detected and we find it later. So if you have somebody who's 30 years old and he have a stroke, you look for everything else. You look for your carotids. There is no plaques, no cholesterol. You look for the heart inside. If there's clot, the heart is excellent and working well. So that's where you kind of suspect it. Now there is data associating PFO with migraine. Some people who have resistant migraine have PFO, and the migraine is due to tiny strokes that's happening and cause you that migraine that's not going away. And I had a patient who had the migraine for 20 years, all medication tried, had a stroke, had a large PFO on 3D echo. We closed it with the PFO occluder, migraine gone, no more strokes. So it's very important to know where to find those patients, and like exam and seeing you and examine you and knowing your story is much better than any exam, then followed with the right tool, and then we go from there.
Is the coronary calcium score testing covered by insurance?
The calcium, I wish it was, and we're pushing for it, and I'm a member of SCCT. We're pushing it from our part, from the Society of Cardiac CT. We're also with all my coworkers that specialize in that testing. And then the insurance yet, it's not covered. What has most centers goes between kind of $100 to like kind of 80 to 100, 120. It's one time and you know the calcium score, but unfortunately is not covered unless we do the CT coronary, which we call it, then we can do both in the same time, then it's covered. So that's when it's indicated to do the CT coronary, the vessels that I showed you that we can see.
Next question is transmetal angina, wow, that was a mouthful, sorry. Angina dangerous, and can it be treated?
So transmetal angina is, it looks like like you can have feeling like you're having a heart attack, but it doesn't cause the same damage that the heart attack happens, because the only difference, if you go to anatomy and know your heart, which is the title of our conference, it's not a clot that's inside, or it's not a plaque of cholesterol, or it's not a thrombus, what we call it. So the flow is minimally, for timely fashion, is closed. It's spasm that happens in the coronary, and there's no flow for a couple of seconds, then it releases. So it's not like a clot that stays and doesn't let your blood pass for a long time, and you end up with heart attack or symptoms. So that's why it doesn't cause damage on the heart unless you have a severe territory and it's longer. That's rare, can happen, but very rare. But usually it's not. But there is a specific treatment for it. Some treatment for the usual chest pain makes it worse. And some treatment they should be like calcium channel blocker usually are, or beta blockers are the mainstay, or medication that helps you relieve that spasm.
Okay. And the next question is, what is the difference in using 3D echo and CT scan and mapping out valves?
So it's very important, as I mentioned, one of the very important tools. When you want to deal with valve, you need to do the 3D echo, you need to do the CT. Especially aortic valve, we'll do it a lot. We've been doing it for the past 10 years. More advancement has happened. We can even simulate a valve and put it on the CT and see how it looks after we did the measurements to make sure and simulated what happens with it. Especially if you have an old valve, big valve that's not working, we can put the valve inside the valve. And also CT is a powerful tool to measure that and measure how much which valve will fit inside. Because imagine you put a small valve, it will fall, or you put a big valve, it will rupture. So it's very important on 3D and 3D because it's dynamic and it's kind of a time resolution, meaning like we can see through time what's happening, and CT is anatomical. So it's very important, the combo, to sit down, and we sit down as a group, and that's what I usually do all the time with those procedures.
The last question we have is, how long are you in the hospital after a TAVR or a mitral clip?
So usually the optimum that we aim for is same day discharge or next day, sometimes 2 days, depending if there is any other things happening during or a complication. So the main issue that we're aiming for, and we're aiming for more than 90% or more, that you're the same day or next day, and that's what's supposed to be.
Let me start by thanking Dr. Samarany so very much for this very informative lecture. It was really wonderful. I'd also like to thank all of you for joining us this evening. And just as a reminder, this is our first of our lecture series. We will be having another lecture on 2/17. Dr. Duber will be doing a presentation on before and after heart attack. So we hope to see you all there virtually. Thank you. Oh, and my contact, just as a reminder, my contact information will be up for anyone who has any questions that they may want to ask at a later time. Thank you again.
Thank you.